why should an intensivist know about autoimmune disease? See, usually autoimmune disease we think like it's for the general medicine or it's for the rheumatologist. So why should I know about the autoimmune diseases? Because first thing, when a patient presents with an autoimmune crisis in the ICU, it most of the time has an atypical presentation. You will end up treating the infection, you will end up giving supportive care, you will end up giving organ support. But then why this infection, why this organ support is needed, what is the presentation and why this is causing is always a question mark. So an autoimmune disease patient is always presenting you in an atypical way. So in that atypical presentation, you have to identify a disease flare and avoid the organ failure and mortality. Most of the autoimmune crisis which presents to us in ICU, they land up in organ failure. So just giving organ support does not help them much than treating their root cause. Second, therapeutics. As we know, the therapeutics involved in treating an autoimmune crisis are mostly steroids or immunosuppressive therapies and other life support measures. So these steroids and immunosuppressive therapies we know have got a list of complications. So we have to balance our therapeutics. We have to make sure that the secondary bacterial infections do not go up because we are giving a therapeutics in the form of steroids or immunosuppressive agents to an autoimmune crisis. And finally, manage the complications, because these people have been sick for a very longer amount of time and we are now pulsing them with steroids. Infections tend to occur, they bounce up to you very badly. Other than that, there are disease exacerbations. It cannot be like a single autoimmune disease only goes in that route. There can be a flaring up of multiple autoimmune diseases at a time and can result in disease exacerbation. So the role of intensivist here is to identify that atypical presentation and get to a cut diagnosis. As early as possible, start the immunosuppressive therapy, manage the complications of immunosuppressive therapy and give some life sustaining support. So what are the common autoimmune disorders which we encounter in ICU? Most of the time we see SLE crisis or scleroderma crisis, we see pulmonary renal syndrome, ILDs or CAPS, that is antiphospholipid antibody syndromes, or some autoimmune hemolytic anemias. So what should you keep in mind? Whenever a patient with scleroderma crisis present, they usually present with malignant hypertension or a hypertensive heart failure. So do not jump into saying this is a hypertensive young male of around 25 years or 30 years presents to you with a BP of 220, 120. Of course, rule out stroke, rule out hemorrhage, look at your echo, do those things. But do not jump saying this is an ischemic heart disease. No. Always also have a background in his mind. Can there be a scleroderma crisis? Why this malignant hypertension? And this hypertension, can this malignant hypertension be the cause of the heart failure? Then what is the reason for this essential hypertension? There is something wrong with this primary hypertension and the root cause of this primary hypertension has to come out. Obviously, most of autoimmune disorders present with AKI requiring dialysis. So management here is mostly managing your hypertension and giving an organ support. Then we have pulmonary renal syndrome. Here patients presents with two more important things. One is hemoptysis and another thing is renal failure. So hemoptysis is causing diffuse alveolar due to diffuse alveolar hemorrhage, causing respiratory failure and necrotizing glomerulonephritis. So here you must be thinking there is so much of hemorrhage happening. How do I purge them with steroids? No. Here the management of choice is steroids, correction of the coagulopathy of course to prevent further hemorrhage and treating your acute respiratory failure as well as your renal failure. You see lot of connective tissue related ILDs. So these ILDs usually present with respiratory failure and ARDS. There is nothing much we can do for these ILDs except for improving their quality of life or subjecting them to, bridging them to transplant by placing an ECMO. So giving them steroids, improving their quality of life, preventing further disease exacerbations, preventing the infective complications in the ILD and bridging them to ECMO and placing them on a list to transplant.